Welcome to the Medical Nursing Podcast, the go-to show for vet nurses and technicians passionate about internal medicine. I'm Laura Jones, a registered vet nurse, all-around medical nursing nerd, and your guide to breaking down complex medical diseases into simple, actionable chunks. Each episode is packed with knowledge and tips that you can start using right away to give even better patient care. So let's get started. Hello and welcome back to the Medical Nursing Podcast, where we talk all about the different small animal internal medicine conditions that we see in practice and the difference that our care makes to them as veterinary nurses and technicians. And if you are listening to the podcast for the very first time today, then a huge welcome to you and thank you for choosing to learn with me today. In this episode, we are finishing our endoscopy series with a less common, but by no means less important procedure, and that is lower urinary tract endoscopy, or cystoscopy as it's better known. Now, this is a relatively uncommon procedure. I had never seen one outside of referral practice, for example, so I'd never ever done one in GP. But just like our other endoscopic procedures, there are loads of different ways that we can put our nursing skills to good use and do more supporting patients who are undergoing urinary investigations. So in this episode, that is exactly what we're going to look at. Over the next half an hour or so, we'll be talking about what urinary endoscopy actually involves, the common indications for it, how we prepare, handle and maintain the equipment that we use, and of course, most importantly, the nursing considerations when supporting patients undergoing these investigations. So I want to start off by talking about the areas of the urinary tract that we actually scope and how we do it. And if you have been here for a while, then you will know that I always do like to revisit our anatomy and physiology, albeit brief, I promise, before we get stuck into the specific disease that we're talking about or the procedure that we're discussing. And I do this because it gives us a much better understanding of what we're doing and how we do it, and cystoscopy is no exception to this. You will see that the kit that we use is very different from patient to patient, and this depends almost entirely on their anatomy. So stick with me for just the next few minutes and then everything else will make a lot more sense as we go on. So cystoscopy or erythrocystoscopy or urinary endoscopy is the endoscopic examination of the lower urinary tract. In females, who actually make up the majority of the patients that we perform this procedure in, this consists of the vaginal vestibule and the vagina itself, the urethral opening and the urethra, the urinary bladder and the ureteral openings, so the points where the two ureters enter the bladder. If we look at the anatomy of the bladder itself, the bladder consists of the apex, which is the top or the most cranial aspect of the bladder, the body, which is the main portion of the bladder, and then the bladder neck, which is the caudal end of the bladder, which ultimately narrows and then funnels into what is going to become the urethra. The ureters enter the bladder, or rather they should enter the bladder, at a region called the trigone, which is a flat triangular section of bladder near the bladder neck. So they actually enter relatively caudally. They don't enter in the top of the bladder or the apex of the bladder like, they would do in people, for example, or they do in the textbook diagrams. The anatomy of the rest of the lower urinary tract, especially the urethra, is entirely dependent on the species and the sex that you are scoping. In a female dog, the urethra is relatively short, it's quite wide and it's straight. So this means that we can use a shorter endoscope and a rigid endoscope to perform cystoscopy. However, in males, the anatomy is completely different, and this means that the kit that we use needs to be different too. Because the urethra is long, it's curved, and it runs through the os penis, you physically cannot pass a rigid scope along it, and so this means that male dogs need to have a flexible scope instead. And this scope needs to not only be flexible, but it also needs to be narrow enough to pass through a very narrow opening. If we think about the size of most urinary catheters that we place in male dogs, they are not huge. You're talking about, 10, 12, maybe 14 French is the biggest, and an opening of around 3 to 4 millimetres at most. So these really have to be very, very narrow endoscopes, narrower than what most of us have in practice. I have put a diagram of the lower urinary tract for both male and female dogs on the show notes, so the companion blog post that accompanies this episode. So if you do want to have a little look at what I mean, you can see where the apex is, where the trigone is, and just how different the urethral anatomy is. Head to the blog, to the show notes that accompany this episode. You'll find the link to them in the description below the episode, and have a look at that. So that is anatomy covered. Let's talk about how a cystoscopy is actually performed. So the first thing to say is that a cystoscopy procedure needs to be performed as a clean, sterile procedure. So clean to sterile. The urinary tract is a clean environment. It's not completely sterile. There is a natural kind of flora of, bacteria in there, just like it has its own microbiome, just like the gut and everywhere else. But it's a clean environment. We don't want to introduce infection, introduce any contamination, because that's going to cause an iatrogenic UTI. So this means that the endoscope needs to be sterile, or if you don't have an autoclavable scope or you can't EO your scope, for example, then cold soaked in instrument disinfectant and then rinsed with sterile water. The procedure should also be performed in a clean environment, and the endoscopist should be wearing sterile gloves for the procedure. After the patient is induced, the prepuce or the perivulval area, depending on whether you're scoping a male or a female, is going to be clipped and aseptically prepared just as you would do for placing a urinary catheter, and then the scope is introduced. The urethra, and if you're scoping a female patient, also the vestibule and the vagina are going to be examined before the scope is advanced into the urinary bladder. Once it's in the bladder, the urine is drained out and it is replaced with warmed sterile saline. This is important because firstly, this distends the bladder, so it fills the bladder, allowing us to thoroughly assess all of it. And also we are replacing that quite opaque yellow concentrated urine that's very hard to see through with clear liquid, which allows the endoscopist to clearly visualise the area. Inside the bladder, the mucosa is examined for evidence of things like masses, erosions, inflammation or other abnormalities, as well as the presence of anything like stones. It's also really important that the clinician, so the endoscopist performing the procedure, locates and visualises each urethral opening and stays at each one long enough to see a jet of urine exit the ureter and enter the bladder. So we're confirming patency of both ureters. After the visual assessment of each area, tissue samples will be collected as needed, and we collect these for things like culture as well as histopathology. Depending on the reason for your patient's cystoscopy, which we will come on to in just a second, we may also need to perform other interventional procedures. So sometimes we will actually perform a cystoscopy to correct an abnormality such as ectopic ureters, where we will do laser ablation of these, or we may even do lithotripsy, which is where we're breaking up stones. At the end of the procedure, the bladder is going to be drained and emptied and the patient recovers from their anaesthetic. They may have some local discomfort, so cystitis type pain, and some urinary changes, which we need to keep a close eye on in recovery, but they can usually go home within sort of 24 to 48 hours, depending on the individual. So that's what a cystoscopy is, but what are the indications for one in our cats and dogs with lower urinary tract disease? Well, just like the other scopes that we've covered across the entire series, cystoscopy tends to be performed quite late in our diagnostic approach to urinary disease. It's not a common procedure in general, especially in male dogs. I've only ever seen 2 male cystoscopies in my entire career. And it also tends to be reserved for patients where other imaging or other diagnostics have not identified the problem. In most cases, patients have already had routine blood work, multiple urine analyses and urine cultures, and also imaging such as ultrasound or a contrast X-ray study. And all of this is usually done before a scope is performed. These diagnostics that have been performed so far may have failed to identify the actual underpinning issue, or it could be that the patient has not responded to appropriate medical treatment as the vet expected. In terms of the signs that we see in patients undergoing cystoscopy, usually these patients have things like chronic or recurrent UTIs which aren't resolving, persistent or recurrent hematuria, dysuria or stranguria, and pollakiuria. Urinary incontinence is also a common reason for cystoscopy, particularly in young female dogs, which is highly suspicious for something like ectopic ureters. In some cases with uroliths, we might see this. We may also scope patients where we suspect they have masses in the bladder, vagina or urethra, trauma to the lower urinary tract, and anatomical abnormalities such as ectopic ureters. Alongside this, we may perform cystoscopy in patients that have abnormal findings on imaging or urine analysis, such as evidence of neoplasia or neoplastic cells on cytology. Out of all of these, the two most common scenarios that I have personally seen cystoscopy performed in are urinary incontinence in young female dogs and hematuria or stranguria in older dogs. So in our young female dogs who are leaking urine, and this has usually been going on for some time, usually since they were a puppy, we are looking for an ectopic ureter. So an ectopic ureter, as the name suggests, is a ureter that enters the urinary tract in an abnormal location, meaning that the urine bypasses the normal urethral sphincters and therefore it leaks out. Cystoscopy is the ideal diagnostic for finding these and defining these because we can directly visualise them, so we can see exactly where in the urinary tract they're landing, how far up the urethra they are, etc. Sometimes we will also do CT scans to identify these as well. If we are doing a cystoscopy, we will actually sometimes correct the abnormality under the same procedure with laser ablation, which is where we open up the division between the ureter and the bladder, allowing urine to enter the bladder more normally. In older dogs who have persistent hematuria or straining or pollakiuria, where we're worried about a mass, we will also often perform cystoscopy. Usually it's urothelial carcinoma or transitional cell carcinoma or TCC that is the one we see most commonly, and cystoscopy allows our clinicians to see kind of how extensive the lesion or lesions are and also take a biopsy to confirm it. Now, there is one species that I haven't really mentioned yet, and that's cats. And the reason for that is because cystoscopy just isn't generally performed in cats, mostly due to their size. In most cats, especially male cats, the urethra is just far too narrow for a scope to fit down it. With that said, most feline lower urinary diseases don't actually need cystoscopy to diagnose them or correct them. So in most cases, it really isn't too much of a problem. But we are predominantly talking about dogs when we are talking about cystoscopy. Next up, we need to talk about the kit that we need and how this is managed. And we've already spoken a little bit about the different scopes that are needed for things like male versus female cystoscopy, but I do want to look at the kit in more detail and talk about how we maintain, handle and prepare it, because of course, this is a big part of our role as veterinary nurses and technicians. So firstly, as we mentioned, the type of scope that we use depends entirely on the patient that we are scoping. We scope our female dogs and very, very, very rarely maybe female cats using a rigid telescope. This is a usually 30-degree rigid rhinoscope with a working sheath, just like we use for rhinoscopy. You can actually use the same scope for both, you just need to make sure that it is sterile before it enters the urinary tract and is handled aseptically. Male dogs need to have a flexible urethra cystoscope, again sterilised before use, or if you don't have EO, cold disinfected. In some cases it may be possible to use a narrow bronchoscope that may be small enough to fit into the urethra, but a cystoscope is preferred, and the reason for this is they are usually very narrow. We're talking 2.5 to 3 millimetres in diameter, and they are long enough to travel the entire urethra and up into the bladder, and in large dogs especially, that's quite a far way for them to have to go. They also have an instrument channel for biopsy collection, but because the scope is narrow, this also means that the instrument channel is going to be narrow. So this means that the biopsies we get are going to be a bit smaller than normal, and this can limit the diagnostic information that we get from them. The scopes will be connected to the endoscopy tower, the camera, the light cable, of course, as needed, as our other scopes would be. Now, most of our flexible urethra cystoscopes will plug directly into the tower without needing an external camera or a light source because they are usually video endoscopes. Rigid telescopes, on the other hand, they will need to be attached to a camera head and a light cable, and this should also be sterile or cold soaked or covered with a sterile camera drape if you have access to those. And then alongside the scope, the camera, the light cable, the tower, we need to think about our ancillary kit. This is going to include things like biopsy forceps, grasping forceps, and stone retrieval baskets, alongside sterile saline and giving sets. And if you're doing interventional procedures, then a diode laser and laser fibre that you can pass down the scope. And of course, for us as veterinary nurses and technicians, a big part of our role is in preparing, handling and maintaining all of this equipment. This involves visually inspecting everything, doing things like leak testing the cystoscope, checking all of its functions before the patient is anaesthetised, white balancing the scope, and ensuring things like the biopsy forceps and other ancillary kit are functional and undamaged before the patient is induced. And then speaking of the kit, after the procedure itself, the items should be cleaned, even just a super quick pre-clean, as soon as possible. This is important because we know that dried blood, fluid, tissue and other proteinaceous material can block the endoscope incredibly quickly. And in a scope that's as narrow as our cystoscopes are, this is even more important. These scopes are also often really quite expensive, especially the flexible ones, because there's a lot of technology that you have to get into a very, very small tubing diameter. So this is, we don't want any scope to be damaged or obstructed, but this is certainly one that we really definitely want to minimise any additional costs of maintenance or repairs. So after the procedure, we want to do a quick patient-side clean to prevent obstruction. This isn't necessarily a full clean, but if you are juggling trying to, recover a patient, sort out samples, tidy everything up and clean the scope, and you also need a break and everything else, doing something to stop that scope from initially obstructing is going to buy you enough time to sort out all of the other things that you need to do and maybe go and grab a quick drink before you do that full clean of your scope. So what we want to do for that quick patient-side clean is suction or flush some pH neutral enzymatic cleaning solution through the channels and then brush through them as well. And then you can safely set the kit aside somewhere that it's not going to get knocked or damaged or anything like that, giving you a bit more time to do all those other things before that full clean is performed. And that full clean is exactly the same as we discussed for our rhinoscope and our bronchoscope in the last two episodes 122 and 123. So the kit is going to be cleaned in a neutral enzymatic cleaning solution. All of the channels are going to be brushed and flushed through, including the ports of the working sheath for our rigid scope, and then the scope itself is going to be gently wiped over. The instruments, the scopes will all then be soaked in that solution for the required duration, and then the process is repeated in high-level disinfectant before the scopes and consumables and forceps and everything else are all rinsed in distilled water. Once everything's dried, it needs to be sterilised, ideally using ethylene oxide, because the rapid heating and cooling cycles in a lot of our kind of benchtop standard autoclaves can damage even autoclavable endoscopes. So make sure that you are following manufacturers' recommendations when it comes to sterilisation. This episode is brought to you by the Veterinary Internal Medicine Nursing On Demand Library Club. And honestly, if you are not already a member, then you're going to want to hear this. For just £21 a month, you get access to the entire Veterinary Internal Medicine Nursing webinar library. That is over 60 hours of CPD, and it's growing month on month on all things internal medicine nursing, and it's available on demand whenever you need it. And it doesn't stop there. Every single month you get a brand new webinar too, plus access to the monthly evidence files live sessions all included. Whether you want to deep dive into a specific topic or just keep your CPD ticking along, the Library Club makes it ridiculously easy for you to do so. There's no contract, you can cancel anytime, and if your clinic gives you a CPD budget, I can even invoice them directly for a yearly subscription. Think of it as your own personal library card for veterinary nursing education. Head to veterinaryinternalmedicinenursing.com and check out the library club to grab yours. The link is waiting for you in the show notes. And now, back to the episode. The next thing to look at is anaesthetic management during cystoscopy and how we nurse these patients in that peri-procedure period. So cystoscopy is always performed under general anaesthetic, and this means that there is a lot of scope for us to support these patients. In terms of anaesthesia protocols, there is not one particular protocol that these patients need, so our job is to collaborate with our vet team after performing a thorough patient assessment to create a multimodal and tailored plan for each individual patient, and then of course monitor them much the same way as we would do any other anaesthetised patient. There are a few specific kind of procedure considerations that it's worth noting when we are monitoring these patients though. So first of all, antibiotics are usually administered around the time of the procedure starting. So much in the same way that we do for surgical procedures where patients will have IV antibiotics at, just prior to initial incision, then they may be repeated every 90 minutes throughout the procedure. We will often administer a dose of IV antibiotics at the start of a cystoscopy. And the reason for that is because we are introducing instruments into the urinary tract, there is a chance of contamination. During the procedure, we also need to monitor carefully for over-distension of the bladder. If the saline that we are using to fill the bladder continues to run in, there is a risk of overfilling of the bladder and even a risk of urinary rupture. So we need to monitor bladder size carefully and alert the vet if we feel like it is becoming too full. And although this isn't a true anaesthetic consideration, it's still an important thing for us to be aware of because it'll probably be us kind of flagging this and reminding the vets about this. But we need to collect a urine sample from the patient before we scope them. If the patient has not had a recent urine analysis and one is going to be needed, this needs to be taken before we introduce any fluids or collect any samples. Because if we're introducing fluid into the bladder, into that sample, we're going to dilute it and change the specific gravity. Also, we might change the pH because we're introducing things like sodium and chloride. And of course, if we're biopsying, anything like that, we're going to be causing bleeding. And that is going to be iatrogenic, but it's going to look like our patient has hematuria. So when the vet's starting the procedure, it's worth just double checking with them if they need a urine sample that can then be collected through the scope channel, assuming your scope is sterile, before the procedure begins. Aside from anaesthetic management, there are several other ways that we can use our skills to support cystoscopy patients as veterinary nurses and technicians. And those other considerations include preparation, fluid management, and sample collection, among other things. So looking at preparation, as I mentioned, this is a clean procedure. This means that we should make sure that the procedure happens early in the procedure list and in a clean environment with sterile equipment. So if we have multiple scopes on the board for the day, the rest of them are going to be done later. It should ideally be cystoscopy first, then out of our other scope types, probably a bronchoscopy, then things like rhinoscopy and GI endoscopy because they are our more contaminated procedures. Second, we need to look at fluid management. So we know that the bladder needs to be clear and full when a cystoscopy is taking place. So once the clinician has introduced the scope into the bladder and collected a urine sample if one is needed, it's usually us as nurses, particularly if we are helping the endoscopist as part of our role in the procedure, who manage this. So we will use a large syringe and a 3-way tap to empty the bladder whilst the clinician holds the scope in place, and then we will carefully refill it with saline, avoiding over-distension, and then just checking to make sure that bladder stays nice and full. We don't want to use a pressure infuser bag, so we do use this with things like rhinoscopy. This is basically a big blood pressure cuff that goes around the fluid bag and squeezes the fluid in. We definitely don't want to use that for a cystoscopy procedure because we don't want to put pressure on that bladder wall. We don't want to be, squeezing lots of fluid into that bladder. And we want to make sure that we are turning the fluid flow down as needed to avoid overfilling. So as the bladder is filled, once the clinician goes in and starts having a look around, there will naturally be some fluid leakage around the scope. And what we want is to hit that kind of sweet spot where the fluid is going in slowly enough to just keep the bladder nice and full so that they can see without over distending the bladder and risking rupture. When we are filling the bladder, we want to make sure we are using warm saline to do this, because cold saline or even room temperature saline is going to potentially increase risk of hypothermia under anaesthetic. That being said, it can be helpful to also have a bag of cold saline on hand as well, especially if there's bleeding, because what we can then do is draw up a little bit of that cold saline, attach it to the ports on one of the endoscope, and then squeeze that manually against the mucosa to cool that area down and try and slow or stop that bleeding. Now, the bladder mucosa is quite delicate and it can also be friable, especially if we've got patients with urinary neoplasia or severe inflammation. So the sites, when we biopsy them, can bleed quite a bit, and that's why I like to have that cold saline on hand in case we want to go ahead and intervene. Now, we're putting a lot of fluid into our patients, and we, of course, with that also need a way to collect that fluid as it drains out. Cystoscopy is a very wet procedure. These patients can easily become soaked if not careful, and this is going to increase their risk of hypothermia even further. And with it, it's also going to increase their risk of things like burns, especially if they've got, heat pads or things like hot dog warming devices underneath them. Even if they're separated by bedding, if that bedding gets wet, we have an increased risk of thermal injury to our patients. So to minimise kind of fluid contamination and the patient becoming soaked, I would recommend performing the procedure on something like a tub table, assuming you have one in a clean area, or failing that, using something like a fluid collection drape to catch the fluid in, which helps to keep your patient dry. This drape is basically a plastic pouch that hangs over the end of a table. It collects all of the fluid and it's got a little tap at the bottom that you can open to drain the fluid out into a bucket, for example. Also, thinking about the bedding that we're using on the procedure table, use something like a vet bed that's nice and wicking, because the patient is then not going to be lying against a wet towel or a wet blanket. That keeps them dry and it also minimises the risk of burns. And then we also need to talk about sampling, because just like our other endoscopic procedures, sample collection is really important. How we collect, handle and store these samples directly affects the pathologist's interpretation, and with this, the information that we get back from the lab and the answers that we get for our patient. In cystoscopy, we're going to be taking several samples for histopathology, with at least one biopsy set aside in sterile saline that's submitted for culture and sensitivity. And for us as veterinary nurses and technicians, we're often the ones handling the instruments, collecting the samples for the vet, and then of course submitting them to the lab for analysis. So a few top tips to help with this process. First of all, if you are advancing forceps in while the vet is holding the scope in place, advance them really gradually, roughly 1 centimetre at a time, and stop if you feel any resistance at all. In male dogs, this is especially common because if we think about the male urinary anatomy, the urethra is long and it has a bend in it. And if you're advancing a urinary catheter, there's naturally a point where you feel more resistance as you're trying to kind of get past and around the os penis. So if we're advancing instruments through a scope that is bent in that position, there's quite a high risk of us damaging the inner channel of that scope as we advance those forceps. So if you feel any resistance, stop and then go nice and slowly. Secondly, keep your instruments closed until you can see that the tip has fully exited the channel or the sheath to avoid damage to the scope from opening those forceps prematurely. Most forceps have a small kind of wing or wire underneath. It looks a little bit kind of V-shaped and it sits under the cups. If you open and close your biopsy forceps, you will see there's a little bit of wire that kind of pops out and goes back in again as the forceps are opened and closed. That sits under the cups of the biopsy forcep. So even if the cups have come out of the end of the scope and you can see those on your screen, if that little wire is still sitting inside the channel, it's going to scratch and damage the inside of the instrument channel and potentially in a flexible scope cause a leak. So we want to make sure there's enough room before they're opened. When we are advised to by the vet, we want to push purposefully but carefully against the area being sampled. close the forceps firmly, and then withdraw them in the fully closed position. Take them all the way out of the scope before they're opening, making sure we are holding those forceps closed throughout to avoid damaging the scope. To free the sample off of the forceps, we want to shake or rinse it into a sterile pot of saline rather than doing something like trying to tease it off of the forceps with a needle, because that needle can damage both the tissue and also the forceps cups themselves. And these forceps that go down our cystoscopes are incredibly narrow. We're talking 1 millimetre usually in most cases, so they are very, very easy to damage, even inadvertently. And then after the procedure, we want to place our culture sample, which is usually the smallest or the worst quality biopsy, in a small pot of saline labelled for culture, and then place the rest of the samples in formalin. Then send them along with a summary of the patient's history, imaging findings, and also details of any medications that they either are on or have had recently, especially antibiotics. This is particularly important because many of our patients will have had recurrent UTIs and received multiple courses of different antibiotics before the procedure. And if we're sending a biopsy off for culture, then the lab need to know which antibiotics the patient has already been treated with, because there may be an increased risk of things like resistance to some antibiotics. And then our nursing care, of course, continues into recovery. Once the procedure's finished, these patients need to be monitored closely until they're fully recovered, and there are a few specific things that we need to look out for when monitoring them. The first is urination. So we really want to see these patients passing urine, ideally with a good stream, so a nice normal stream of urine before they go home. There's a risk of things like urethral swelling and inflammation and blood clots, which in severe cases could even be obstructive after a cystoscopy procedure. So we definitely want to make sure our patient can urinate comfortably and pass a normal stream of urine before they go home. It's a good idea to maybe video this. If they're outside urinating, just take a quick video of this, show this to the vet so that they can see exactly what their urination looks like. The next thing to talk about is pain. So these patients can be uncomfortable around the area after the procedure. And this means that monitoring pain scores and administering appropriate analgesia under veterinary direction is really important. And closely related to this, we also need to prevent interference. Because they are uncomfortable, and that might be kind of in the urethra and in the bladder, but it can also be around the area because we've been shaving them, cleaning them. It's probably going to be a bit itchy where it's been shaved, for example. All of this means that they are traumatizing the area quite commonly. If they are given the chance, they will often lick and lick and lick at the area. And this can easily cause further inflammation and infection. So we do want to make sure that we've got an Elizabethan collar on these patients in recovery. And then aside from this, the rest of our considerations are pretty similar to any other patient. We also want to make sure that we are talking to our clients about what to monitor for, what to expect in ongoing recovery at home, and when they should return to see us, as well as any other specific considerations, of course, based on the individual patient's needs. And then depending on what the results come back with, dictates kind of the next steps going forward. So there you have it. That is an overview of urethrocystoscopy in dogs. So when and why it's performed, how it's performed, and of course, our role in all of this as veterinary nurses and technicians. To sum up everything that we have chatted about in the last 32-ish minutes, we know that cystoscopy is the direct endoscopic examination of the lower urinary tract. So the vestibule, the vagina, the urethra, the bladder, and the ureteral openings at the trigone. It's performed when our workup so far has not revealed a specific cause, or where, of course, appropriate medical management has not resolved the patient's clinical signs. Usually, it's patients that have recurrent UTIs, hematuria or straining, incontinence, masses, or anatomical abnormalities that we perform cystoscopy in. And although it is a relatively uncommon procedure overall, it's almost never performed in cats. So in most cases, it's going to be our dogs that we are supporting through this. Our nursing role is really vast, and it includes selecting, preparing, and managing all of the equipment, creating tailored anaesthetic plans under veterinary direction and prescription, and continuing that care throughout and after the procedure. From aseptic setup, positioning, site preparation, kit management, preventing overdistension of the bladder, helping to manage bleeding, monitoring urination, and much, much more. There are so many ways that we can use our skills to support these patients. So that is everything that I have for you this week on this guide to urinary tract endoscopy, and everything that I have for you this series on endoscopy in general. I hope that the last 5 episodes have helped you to confidently care for your endoscopy patients and given you a good idea of just how much of a difference that we can make to these patients as veterinary nurses and technicians. If you found the episode helpful, please don't forget to share it with a colleague who would find it helpful too. Leave a review and a rating of the podcast. They really help me to grow the podcast, help it reach new ears, and therefore help it impact more patients. As always, I love hearing from you. So if you have anything you want to share with me, any cases you want to chat about, let me know. Have you ever seen a cystoscopy done before? If you have, what was going on with your patient and what was your role in the process? Drop me a DM on Instagram. I'm at Vet Internal Medicine Nursing. I cannot wait to chat to you, and I will see you very, very soon in another episode. Bye.
If you've made it this far, then thank you so much for listening all the way to the end of the episode. And I have one more thing to ask of you before you go today. I would love to hear from you. Yes, you. I love hearing about the cases that you're seeing, the skills that you're using, and the conditions that you want to learn more about. Drop me a DM on Instagram. I'm at Vet Internal Medicine Nursing, and don't be shy. Come on over, say hello, and tell me a bit more about you. Talk to you soon.